Good afternoon, everybody, and welcome to the Health Current session on birth to death, HIE across the lifespan. My name is Dave Vopel. I'm with the Arizona Healthcare Association, and we have an awesome panelist for you today. We're going to spend the next hour with you and really talk about what's going on the HIE side from the minute you're born to when you pass away, really. So let me do a quick intro of our panelist. First up, we have Dr. Roy Jadakin. He's the medical director for Phoenix Children's Care Network here in Maricopa County. He's a pediatric cardiologist with a focus on quality improvement and services for infants, children, and young people. Next, we have Amy Malkin. She is the COO, Chief Operating Officer for Pioneer Health Group. Her main focus is really in Santa Rita Nursing and Rehabilitation Center in Green Valley, Arizona. And Amy and I know each other, evidently not very well since I just called her Rita, and because she's on the Arizona Healthcare Board of Directors. So, hi, Amy. Next, we have Dr. Charlton Wilson. He is with Mercy Care Health Plans. He is the Chief Medical Officer, and he oversees the numerous medical and clinical programs for populations served by both Medicare and Medicaid, including the largest integrated behavioral health service program in Arizona. Next, we have Jason Schmidt. Sorry, Jason, kind of muffed that one too. He's the Chief Executive Officer for Arizona Home Care, the largest locally owned home health agency in the Valley of the Sun. So welcome to our panelists. Thanks for spending the next hour with us. And I want to start with Dr. Roy Jadakin. Dr. Roy, how are you today? Oh, you're on mute.
Unmute, there you go. Well, thank you, David, and just would like to thank the organizers for the participation opportunity and the esteemed colleagues on this panel.
Very good. So tell us a little bit about Phoenix Children's Care Network. I mean, you're kind of the birth side of this thing as far as I can see. What do you see from the HIE perspective? How long have you been with Health Current or with the HIE? How long have you been using it? Kind of open up a little bit for us on that end of it.
Good. Well, thank you. So as I was thinking and looking at the title, I proposed an extension or change from conception to death. And the reason I say that is actually in healthcare starts certainly with the life cycle at conception. And I'll go into my the PCCN, but conception is really the beginning of healthcare opportunities. And so Phoenix Children's Care Network is a clinically integrated network. We're the largest pediatric clinically integrated network in the Southwest. Our association with HIE started in 2019, and more recently we're looking to enhance that relationship more meaningfully and really relating to child health as an opportunity beyond hospital care and in the ambulatory space. We have value-based contracts with numerous payers, both in the Medicaid and in the commercial space. And we have on the other interface contracts with providers who then are involved in our vision and mission of quality, culture engagement, with cost containment from the contractual point of view. Just to give you some perspective, I'm just going to look to the left. We have 1,134 total pediatric providers, quite a large organization. We have 178 unique locations, therefore access to care is a great opportunity for our integrated network. We have 383 primary care providers in about 100 practices. We have, and this is, I think, again, integrated healthcare. We have 680 specialists, 67 ancillary providers, and we cover about 170,000 lives. So this is a great opportunity for us as a clinically integrated network to achieve our mission and vision, which is patient family centered. And obviously the HIE opportunity is growing, and I think from the presentations in the last 2 days, the need for essential 21st transparent, timely, accurate data sharing amongst stakeholders in the healthcare industry really presents Health Current with a wonderful opportunity to create meaningful and purposeful links towards healthcare and the child's healthcare space.
Excellent. That's a lot of lives. Let's go from that side of the spectrum. Amy, I'm going to kick it over to you. So what do you see on your end? You've got Santa Rita there in Green Valley, and you have assisted living, skilled nursing. You've been in the healthcare space for quite some time now. So tell us a little bit about you and really your background with the HIE, how long you've been using it, and what it means to the folks you serve.
So we were really excited to have the opportunity to be a part of the HIE. It definitely helps with continuity of care, the transitions that we have. They're so important for us to be able to know what's going on when we do have to send somebody out. We're able to pull those records fairly easily as long as the resident or patient has consented to that. So we've added that into our admission agreement, and so they consent to that upon admission, and then we have the ability to pull those. So a lot of stuff that skilled nursing facilities are doing now is subacute care. We are penalized. The hospitals can be penalized for readmission rates. So we want to be able to drill down on those readmissions, and so it's much quicker for us to have that real-time access to information, to be able to go in and pull it off the HIE and do our deep dive on any readmissions that we've had.
Excellent. Yeah, that's good. Okay. Next, I want to talk to Dr. Wilson. So Mercy Care Plans, you cover the whole spectrum here. So talk to us a little bit about what you see on the HIE. How long have you been a participant with it? And kind of bridge that gap between birth and or conception to death, really.
Well, thank you. Mercy Care is a nonprofit health plan that operates here in the state of Arizona and works primarily with the state of Arizona's Medicaid program, which we know is Access, Arizona Healthcare Cost Containment System, covering not only acute care lives, but also working with them on long-term supports and services known as ALTECs in this state. And we've been participant in the integration of physical and behavioral health from the beginning with our populations that serve persons with a serious mental illness. We also work with other state agencies, for example, the Department of Economic Security and the Division of Developmental Disabilities. We have a contract with them to be a DDD health plan that operates statewide, serving those people who have eligibility under the DDD system and providing integrated physical and behavioral health services for them. And we're entering into a partnership with the Department of Child Safety that will begin next spring, in which we will be providing integrated services for those children who are in the child welfare system, and really looking forward to that. So as you point out there, that begins from conception and wellness care all the way through well child care and ultimately special populations, those perhaps with developmental disabilities or who develop a serious mental illness. And then through the long-term care program, although there are people as in childhood who have long-term care benefits, and certainly DDD is an ALTECs program as well. Certainly it reflects a large portion of their population. Medicaid covers about 2/3 of all days in institutional settings. And so it's a major part in working with other partners here on this panel even are very critical to being able to deliver services for some of our most needy members. We've been with the HIE, as far as I know, from the beginning as an Access Health Plan, and I'm proud that we have people who participate on the board and on various committees to work it through. On a technical end, we certainly, and I would be the last person to actually know what the right technical aspects are, but we send all of the information back and forth on our full membership in a two-way exchange process that allows us to sort of reap the benefits. And later on, when we talk about some of those opportunities that have come along, I know that will come up. But you know, the other thing that I think of when we think about when Mercy Care thinks about the HIE and Health Current is not only as this technical a device that shares information and talks between different payers, but is also, it's a real convener. It's a way of sort of pulling people together. It gives us a common reason to work together, whether it's across health plans or with health plans and providers or hospitals and providers. And an example of that is actually we partnered with Health Current to actually get a grant from Centers for Medicare and Medicaid Innovations, which is called a Practice Innovation Institute, and it allowed us to sort of work together with some providers to help them connect with the HIE and to implement activities that will help them succeed in a value-based world in the future. So I really want to highlight that aspect that the Health Information Exchange also is a convener of us in multiple different stakeholder seats.
Yeah, that makes sense. Excellent, excellent. Jason, I'm going to kick it over to you. Chief Executive Officer for the largest home health agency here in the Valley. So what's your organization's, what's your mission? How long have you been working with Health Current? And tell us a little bit about how that's all working.
Sure. I should probably amend that to one of the largest locally owned home health agencies. I don't want to.
Still big.
I don't want to exaggerate.
All right, we'll go with that.
Not on camera anyway. But Arizona Home Care started about 25 years ago. My brother and I started it. It was initially a home infusion pharmacy, and then it grew. And a couple years later, we started a Medicare certified home health agency. And now it includes a nuclear pharmacy. And so we are primarily on the home care side and the home infusion side, a post-acute provider. So transitioning patients from the hospital or from a skilled nursing facility like one of Amy's facilities to home. And maybe from home, and then there's another transition after that, whether it be hospice. But most of what we do is intermittent care. It's typically not long-term. You know, the home infusion is your average stay is 6 weeks, something like that. But, you know, in terms, so that's kind of our model. You know, we have several different payers. Medicare is important, commercial payers. We're affiliated with some ACOs where there's many of the post-acute networks have providers that they like, preferred providers. And so we are named to many of those in the Valley. And I don't know what else I was going to say about that, but in terms of the HIE involvement, I think we were, again, I don't want to exaggerate, I think one of the earliest home care agencies to be to get enrolled, and certainly one of the first IV pharmacies to be enrolled and be sharing data bidirectionally. It's been interesting. You know, I don't know how much we want to hear this, but sometimes the discharge from an acute setting is not always really clean. Sometimes it's hard. It's challenging. These patients.
I don't think that's a shocker to anybody, to be honest.
You know, the reality is that the patient doesn't really know if they can handle being at home. And they think they want to go to a skilled nursing facility and then they don't, or they think they want to be at home. And maybe the hospital knows that the patient isn't appropriate for home, but darn it, they want to try it. And so we're in the middle of that. And honestly, one of the useful tools that we find with Health Currents is tracking patients. So they went home. They got overwhelmed with this, with these IVs and wound vacs and LVADs. I mean, we handle a fairly fairly sick population. And it's one thing to be at the hospital and think you can handle it. It's another thing when it's just you and your adult children. And so, needless to say, they show up at the emergency room at all hours. And of course, they're not thinking about calling us. They've got enough on their plate. And so it's the next day, and we're supposed to see them again and change their PICC line dressing, or add another TPN bag, and they're not home, and we typically are getting alerts. So we're tracking our patients through the HIE. When we first started, tracking patient information out of the hospitals through Health Current was a really big boon for us. We didn't have to call the hospital or the discharge planner or the case manager to get some additional information. We were able to pull it directly without having to call someone, and it just made us easier to use. We were less of a burden to the referring facility. So yeah, HIE has been, and Health Current has been a delight to work with, and helps us be more efficient and provide better care.
Sure. So Dr. Roy, Dr. Janakin, let's talk about the HIE's impact in Phoenix Children's Network, really about patient care and safety. What does that mean from the children's perspective, or from your agency's perspective? How does Health Current and the HIE, how does that really impact patient care?
So I think that the way we look at that is we define who our stakeholders are, and our stakeholders are the payers, the providers, families, and patients, and the community. And then in order to run a successful clinically integrated network in today's contemporary environment, and also because of the gaps in care and the gaps in our healthcare system, data becomes the most important element for decision-making, for defining best practices, for defining quality initiative opportunities. So for us, we look at our contractual relationships as to what the quality measures are. What are the data elements that are required? We have a very robust data analytics team internally, and we have a tremendous relationship with the payers, with numerous joint operating committees. They are working with their quality individuals, and they, as Charlton knows, have really they have a great support. Now, the source of data is always the issue, correct? And therein lies the major problem in our healthcare system. The source of data is fragmented, is unreliable, is not timely, and again, in many components of our system, behavioral health, for example, discharge from the hospital, 7-day follow-up, 30-day follow-up. These are HEDIS measures, but they're patient safety measures, patient measures where if they didn't get the follow-up from a hospitalization, they may have an adverse outcome. So if we don't have the data that's real time, that is not claims data that's 2-3 months late, we can't really intervene effectively from a clinical point of view. So I think that future state in HIE Health Current is such that these interoperable opportunities between all the stakeholders is going to be key for us as a pediatric clinically integrated network, really to achieve our mission again vision, and really to have a meaningful and purposeful relationship with the stakeholders, who providers. And again, we have a very interesting system in Arizona, and certainly in the metropolitan area. We don't have the large healthcare systems like at Boston Children's, Texas Children's, where they're part of a large enterprise. We have a different type of model here. And I think in our state especially, it behooves us in the healthcare industry that the data interoperability is transparent, is as complete as it can be, and is shared amongst all and to all stakeholders. at the end of the day, with the focus being optimizing the Institute of Medicine's 6 aims, quality aims, which I'll not talk about, and also really to close the quality chasm that the Institute of Medicine spoke about in the 1990s and 2000. We have a long way to go, but I think that we're proud to partner with the stakeholders I mentioned, and I think we're proud to look into opportunities for 21st century data sharing, data completeness, again, with the focus that the patient and families come first in an environment where we have fragmented data systems. There should be mandates where there is a common language, there are common requirements, and therefore, when you put those elements into place, what you do is you decrease the variation, increase the pertinence of the relationships, and we at PCCN really, with Health Current and with our stakeholders, feel that our future is in the right direction as we directly deal with these very important issues.
Very good. Amy, I want to talk about the other side of the spectrum and what the impact is on patient care with the HIE there at Santa Rita. How do you see that? We've heard from Dr. Jadakin there on their end. What about on yours?
So like I had mentioned before, we were able to pull a lot of the information from the hospitals that maybe we weren't given upon admission. A lot of times it's going to be the attending asking for the operative report. Maybe the speech pathologist, wants to see a swallow study. And sometimes that stuff isn't included in that packet. So instead of having to go through a medical records request, we can just jump right on there and pull that information off in real time for those clinicians. The other thing we found really helpful with this, and I was kind of surprised, it just kind of caught me off guard one day, is we admitted an elderly lady who was having some cognition issues. She couldn't remember her other son's name. And the one son that she remembered and that we had the phone number for was not interested in assisting his mother. So we were able to get into Health Current, the HIE, and we were able to pull the other son's contact information off, which was really helpful. So we were able to contact him. He lived 30 minutes away. He came right over. If we didn't have that, I don't know what we would have done with, we would have treated her, of course, taken care of her, but, it's really important with seniors that you have that family involvement. So it's been real helpful with that also.
That's a good example. I got you.
Yeah.
Jason, how about before I go, I want to go back to Dr. Wilson, but Dr. Wilson, I'm going to leave you for after Jason's comments, because I'd like to really, I kind of view you as the umbrella here, because you're over all sorts of, you're over the whole spectrum. Jason, what about on your end? What do you really see as the patient care derivative piece of the HIE? How's it helped, basically?
Sure. Well, without sounding too repetitive, it especially on the home infusion side, that the clock is ticking on that admission. I mean, it almost always the doses are timed, and if there was an 8 a.m. Vanco in the hospital, and then they discharge the patient at 4:30 in the afternoon, I've got to make sure that I have a nurse and the supplies and all of that in the home ready to do an 8 p.m. dose. And there's times when, to me, the perfect example is the PIC placement. So many times the IV administration is done in peripheral while they're in the hospital. And then all of a sudden they realize that, I shouldn't say all of a sudden, but close to discharge, the infectious disease doctor is going to want 6 weeks of IV antibiotics in the home. That means that they're going to need to place a PIC. And that PIC placement, the peripherally inserted central catheter, that is going to almost very often is installed in placed in those last few hours before discharge. And so finding that information to get to our nurse so that we can safely administer that in a timely fashion is a nightmare, to put it kindly. And it's a struggle. And the HIE, Health Current has helped us tremendously in being able to go directly into the EMRs and essentially and get the information that we need so that the nurse feels comfortable knowing that the PIC is properly placed before it was used in the home setting.
Yeah, that's excellent. Dr. Wilson, how do you see all of this from Mercy Care perspective across the state of Arizona, dealing with the whole spectrum? How do you see the HIE covering all that and really making a difference in patients' lives? Just the same question of our providers here, but of you from a health plan perspective.
And the only thing I'm going to switch is I'm going to say that my job is not to be over it all, but actually to support each one of these providers, because it's providers and the patients that make healthcare work. So we really look at our role as to how do we optimize that system, coordinate and fill gaps where we can. And some of the exciting, I know in a little while we're probably going to talk about COVID and the sort of the impact it's had on some of our programs and how it's really accelerated our thinking about the HIE. But I want to tell you some things that we're doing today by using the HIE data. One of which is care management. And Jason mentioned finding people and where they are. It is a fantastic tool within a care management to identify where people are at, because you get some almost either real-time or near real-time information about where people are. And in our sometimes very vulnerable populations, typical things like addresses and phone numbers aren't as reliable as actually finding out where people are accessing healthcare. Another thing that's really important is we've done a lot to try to make sure that the administrative burden of healthcare is as small as possible, but it is a publicly funded situation and there are some duties and responsibilities for appropriate quality management and appropriate utilization processes of public funds. But one of the most biggest challenges that exists in this, as Roy has brought up, is, and Amy as well, is missing information, not having the information necessary. And historically, we would fax each other and fax back and then phone and phone back and then recall, and taking that part out of the administrative burden and saying, you know what, there's information that might be available on this that will allow us to be good stewards on the HIE. So we've already begun to look at things, and Amy brought this up, being able to find that operative discharge or that operative report or the discharge information that we know must have that information, but instead of faxing somebody's office who would then fax somebody else, finding that information and filling in that missing information so that the process works smoother while taking off the administrative burden. And in a couple of other areas that just to sort of mention there, I think it's really important for us also to make sure that we're doing what we can as a health plan and as a health system process, including, and I know Access is a big proponent of this as well. How do we actually help and reward and incentivize providers to be able to have this information and work in ways that actually rewards their use for information, either through value-based contracting or appropriately awarding differential adjusted payments or other things like that, that rewards and actually invests in practices so that they can make that necessary investment that will allow, that they can make that investment that will allow them to connect. And there's a lot of technical details to that, as well as workflow details that I hope to talk about later as well.
Well, I want to stick with you, Dr. Wilson, because you mentioned COVID. I mean, it's been a tough time all the way around, all year long. 2020 has not been our friend, really. I want you to talk a little bit about what some of the changes that have occurred during this time frame, good and bad. I mean, all the way around. What's happened as far as the HIE is concerned and things like that. So if you give us a little bit of background.
I would love to. And in fact, you know, so what I would say is if I was on this panel back in January or early February, I'd be talking about maybe a little bit more theoretical, or maybe what we're going to do in the future. And yeah, we had about 5 registered users, and there's a little bit of use. And we saw great potential, but we'd scratch our heads and say, yeah, maybe next time about some application on a daily basis. When COVID came along, all of a sudden, things changed. One, real-time lab alerts became possible and even promoted, and actually knowing who was getting tested as a sign of perhaps at risk or concern, where that testing was occurring and what that result was, allowed us to actually say, this is a person who's going to need assistance, maybe because they're doing well and need to be able to quarantine at home. Also, though, maybe that they're in a hospital or even a congregate setting or things like that, and we need to bring extra resources and make sure that they can be as well taken care of as possible. Who are those providers who now are facing additional burden because of COVID? It really leapt us from being we kind of look at things in retrospect and sort of think of how things should be, into we're a real-time part of healthcare delivery, and what can we do that would actually change the way we work so that we can move into that real-time or near real-time reactions for providers to make sure that they have the resources they need, whether it's that to connect people so that they can go from the hospital right to home in a safe environment with all the infusion or oxygen and all the other things that they need, or anywhere in between, all the way back to it's a family with needs for a young family. So that made a big difference. And just in this example, we went from 5 registered users to 500 registered users during this time. And all of a sudden, people began to say, you know what, now that I have this information, I'm finding and discovering new ways to do it. Where is my patient that I'm a case manager for in long-term care? Or where is, I have a request here for something. I bet there's information out there that would allow me to get a better complete picture and get this service even authorized quicker than it would have had been in old ways. So it was an accelerator of the need for real-time management, as Roy sort of brought up, the really need for that data sharing. It really created that great use case. And then out of that, people said, you know what, I have about 5 other use cases. I'm going to see if it works. It's been a really positive disruption is what I would say.
Well, from that perspective, that's for sure. How about Amy? I want to kick it over to you and talk about COVID for a minute and the HIE, and talk about how things have changed during this time frame for you and your use of the HIE.
So we were one of the buildings that got hit pretty hard with COVID in the last week of April, or last week of March, beginning of April. It did give us the ability to go in and check on our patients, our residents that were transferred over to the hospital setting, which was nice, because we can see it in real time how they were doing, if we needed to, save their bed, what kind of talks we were going to be having with the family, kind of help us prepare for that. The other thing that's been really helpful is the real-time alerts, where we do get an email for any COVID tests that is in our patient group. So we get the email for those results. And we're actually finding that we're getting those emails before we're getting the results back from Sonora Quest at times.
Wow.
So
that's unique.
Yeah.
The information before the information even gets to you.
Yeah. So it's been very helpful. We're able to take those patients, let them know that they're negative prior to even getting the results from the lab.
Fantastic. Wow, that's cool. Jason, how about you? On the COVID side, what's changed?
Yeah, I would say it's more of the same. Like we've just heard, most of our we had what we called liaisons out in the field, inside of the hospital, helping. Even though there was a lot of technology available, there was just something to be said for the face-to-face interaction in terms of getting, especially the missing information. So obviously that stopped. entirely, and we haven't been back. And so, again, Health Current allowed us access to get the missing data points that we needed to make sure that we were going to be providing safe care. And so, yeah, the tracking of the patient and the missing information has been is just a whole nother level when there isn't access like you used to have.
Sure.
So that was a big thing for us.
Yeah, that makes sense. Dr. Jadakin, I think you're probably going to tell me about the same thing, but I think you're going to put a different spin on it, unless I'm missing something here.
You know, it's very interesting. First of all, we did receive alerts from Health Current, which were very helpful. But I'd like to share with you, so when a system is challenged, as we as a healthcare system are and have been and will be challenged with COVID, it's very interesting how we adapt, pivot, and innovate. And I think that you're hearing from the other panelists is that's exactly with support from HIE and other areas. That's what our community has done. Just like to share with you, just from the PCCN point of view, some of the pivots that we had to adapt to and adopt in our space. So obviously we have contractual measures, which are performance measures, which really are healthcare components, such as well visits, etc., immunizations. And as we know, people were very fearful to go into the offices for well checks. So telehealth, and that is something that I think is an opportunity for future HIEs to look at how does that interoperability come. Telehealth has changed as it was adapted in the business world to the healthcare world. So what we did is we had these contractual measures, and we looked at the interface, David, of where are the interfaces that we as a network need to really look at and adapt during this COVID pandemic. And so at the provider level, key components were, how can we help you? What's happening with financial burdens? What's happening with protective gear, etc. So we had a work group led by Christy Holmes, who was our chairman of the board of managers, and we gave weekly updates to the practices of providers, CDC information, etc., etc. On the other side of it, we also had patients and families as stakeholders, and therefore that interface with our payers was very important. So again, we knew that there would be a huge disruption in well child visits, immunizations, etc., etc. So we pivoted using our two clinical teams, which is a practice integration team at the interface with practices, and our care management team, which is at the interface with complex children, families with different needs. So we developed two outreach programs. One is through the care management team, we made phone calls to the practices connecting patients for their well child visits and in whom gaps in care were identified. We outreached through that mechanism about 12,000 patients. And then we also did auto texting to the families. Child is due for a visit, minimizing gaps in care, enhancing quality of care, to 20,000. We outreached during this time about 37,000 children and their families. So again, the opportunity with data from payers, data from HIE, data internally, driving quality decision-making in a very disrupted environment. So I think at the end of the day, you know, the key point here is, who are your stakeholders, where are your interfaces, and how do you pivot using data that's sort of allows the interoperability of clinical functionality.
Mm-hmm. Excellent, excellent. Jason, I've been given a ton of power here, and I can make you king for the day. So I knight you, make you king. I don't know what, you know, I guess knight's less than a king. So I'm going to elevate you to king now, and you get to be there for the day. what would you do differently with the HIE, whether it's during COVID times, during present time, whatever? Give me something that you'd do differently if you had the power.
First, I'd keep my new status out of earshot from my wife. Second, because that would only cause problems. I think that the thing that strikes me the most is the med rec. The medicine reconciliation that takes place, because we see it. I mean, boy, do we see it. I wish I could share a photo I have of it was in a patient's kitchen, and it was capsules, and it was about 4 feet long and about 2 feet, about 2 bottles deep of all the different medicines that were in the home. I hope that she wasn't on them all. The nurse took a picture of it. But my point being that, as we all know, what the PCP knows is different from what the hospital knows, and which is different from when we get to the home. And we're in a really unique spot, the home care agency is, to know what they're actually taking. I mean, we're probably better situated than most. So to make a long story longer, I wish there was a more communication and more AI in terms of identifying meds that just the med reconciliation would be my top one. Because to me that because meds and NDCs and all of those things are so regulated, and so that it's clean data for the most part. I think that would it be pretty easy for the AI to say, hey, should this patient really be on 3 different blood pressure medications at the same time? Apparently mine's plummeting. That would kind of be my big thing. And I suppose my second ask, which is probably huge, and I have no idea how much penetration we have today, but getting the PCP population integrated, because obviously the big stakeholders, the payers and the networks and the hospitals and the skilled nursing facilities, they all get it, and they're all connected for the most part. I mean, I think our hospital connection rate is what, 98, 99%, some crazy number. But just imagine if the community at large, the primary care physicians and the specialties were all connected as well. That would take us just to that next level. So
Good.
those are my two simple asks.
Okay, simple asks. Yeah. Poof, done. Okay, Dr. Wilson, guess what? You're up. You're king for the day. What would you do?
Well, fantastic. The first thing I would do, with or without COVID, I would bring in backfill for everybody, and I'd give every healthcare provider in Arizona the morning off, and give them a little time to sort of clear their mind and take a break, because people have been working so hard and we're so thankful to them. And then in the afternoon, I'd pull us together. And since I'm still this elevated status here, I would really bring that resource to Health Current to be able to build upon their great account managers and other resource staff that they have that are thinking through. Because I think we all, and it sort of goes to what Jason mentioned, how can we redesign the way our practices are delivered? And I'd bring in the policymakers and the accountants and everybody, all the other stakeholders who are a part of healthcare, and say, how can we redesign the delivery of healthcare so that we focus a little bit more on how to use all this modern information that we have to us? How do we integrate that into our processes? Whether it's, let's get a clean a clean med rec process, or let's make sure that if we're understanding how we're doing around our quality measures, that we all agree how we're going to do it and make it work so that it's a standard workflow process. That way, when my kingdom is done at 5 o'clock, I'm guessing, you know, at the end of the day, whatever you have given me, Dave. But the next day when we come back in, that we go, you know what, sort of that building off of what our team experienced in the heat of COVID, I've now redesigned my work a little bit better so that my workflow and the information and the technology that exist out there work together to help me deliver better care.
Good points. Yeah, and yeah, taking the morning off sounds pretty good too. So, Amy, what would you do after? I mean, obviously you could give them the morning off, but you know, you're now queen for the day. So, what would you do?
I would like to see more input from primary care physicians also. I think that's a huge missing piece that would be very helpful, especially in the subacute wing, where you know those primary care physicians have built a rapport and they really know the goals of care for those patients. It would be a lot easier for us to just be able to pull that off because they're very busy in their practices and they don't always have time to return calls timely. And I understand that. Getting advanced directives in there on everybody would be awesome, as well as power of attorney documentation that we'd be able to just pull from there. That would be really helpful in our space.
Yeah, that's a real good point. I know Health Current's leading the charge on that, especially after the legislation that was passed this last year, giving them the authority to get it from the Secretary of State. So we're looking forward to having that happen because that could be huge.
Yes.
Dr. Jadakin, king for the day, what would you do?
Use my magic wand. As my colleague, Dr. Jody Carter would say. So, I mean, I think I started the premise that data is synonymous with quality, but I think quality, we have some understanding. Data elements and its congruency among stakeholders is a huge issue. So I think that we have an opportunity in the state of Arizona to take the appropriate stakeholders, and I would be the ruler of that roost, and say we would define who those stakeholders were and really have meaningful, purposeful, timely 21st century discussions around it. We have too much fragmentation in order to achieve the quality component of all those of the data elements. I think that Health Current as a vehicle, as a partner in integration of appropriate, accurate data is a great opportunity. I think that we need as a society to think not only of acute care, hospital care, emergency rooms is where it all takes place. We have to look at where the numbers are, where is care delivered, and how do we, in the ambulatory space, in the chronic care facilities, how do we move those needles forward? The hospital systems, the ED systems, their data and the complexity and the sophistication is at an advanced level. In the ambulatory space, because of the different EHRs, because of the different practices, because of, you know, everybody's got different missions and visions, we have the fragmentation. So I think if we could start by saying, how do we use Health Current? How do we use uniform data in the ambulatory space, chronic disease states, chronic care facilities, to take that audience or that population, don't throw them in with everybody else, which is what we tend to do, unfortunately. And I think we have to differentiate that child health and adult health are two different spaces in our society. And I think that if we could start developing child health stakeholders that provide meaningful adoption, we have tremendous number of vulnerable families. Social determinants of health, adverse childhood experiences are all opportunities for data to be optimized.
Excellent point. Excellent. You're talking about, if I heard you right, taking the spectrum of healthcare and really making it less of a spectrum, but more of a ruler type, to where you have each provider group that's in there, whether it's going from conception to death, right?
Well, I mean, you look at this new concept of whole care, whole patient care, whole population.
Sure.
I think it's critical. But each that book has different chapters that are critical to the completeness of a book and its chapters. And so I think that child health is a different chapter within the health, well, whole health space. So we need to be careful.
Excellent point. I kind of want to stay along these same lines, and I want you to put your crystal ball into play, and I want you to look out into the future as far as you want to look, as far as you can. And what does really the HIE look like to you in the future as far as your population is concerned, as far as the programs that you serve? Dr. Wilson, I'm going to start with you, and tell us what you think what the future holds for HIE and Mercy Care and how that all works into play.
Well, I think we're going to continue to look to HIE and as a location where we get that whole person view, whether that's in our utilization management or care management processes, but we're going to extend that out into the social determinants of health and identify food and housing issues and other things, that information that will help that person live better. And I'm really thankful to Amy for raising the issues of advanced care planning documents and other things like that, because that'll help us understand as a system and a process, what are the person's wishes and perspectives. And I think that really sort of feeds into the next part that I think it will be, is we'll think more and more, how do we use this information to address the patient, the person, where they are right now, not in some abstract, here's what happened last year view, but hey, based on some information that we have, and hopefully with transparency around it, that says, hey, it looks like you could use some help right now. And our patients, your patients, our members begin to say, that was really useful to me. That really helped me. I'm glad that the system is out there supporting me when I need it. And then I think in and around all of that, it really goes to, we will begin to think differently about what our individual roles are, and we'll actually work a lot more collaboratively across the process, because by seeing the whole, I think each of us will recognize where we add value into that patient, that member's life experience.
Yeah, that's good. Yeah, that makes sense. Amy, I'm going to kick it over to you. What do you see for the future of the HIE and the SNF AL, the post-acute world?
My hope would be that as more and more people are onboarded, that we would be able to reduce a lot of the testing that our seniors go through, duplicate testing that, they might have had a procedure or a CT scan in the hospital. They get into assisted living, they see the primary doesn't have access to that. So as more and more people are onboarded into it, then my hope is that they'll be able to reduce some of the testing that has to be done, diagnostics.
That's a really good point, Amy. That's a fantastic point. Jason, how about you?
I think in our world, it will be the onboarding process is just going to continue to get more efficient in terms of using these type of technologies, these health current to make that onboarding process more effective and more efficient, because sometimes it's a little sloppy when the fax machine goes off. It's just like, why do I still have a fax machine? And I think the other thing that strikes me is the mobility of it. I'm 53. So I think my warranty is like officially up, and I have to go do a bunch of tests. And I filled out demographics like 4 or 5 times in the last few weeks. 7 or 8 pages. It was the identical data set for all these different specialties. And I was just shaking my head that here I am in 2020. And I'm still filling out demographics. and it kind of bumps me out. But I know that that Health Current is an important partner in seeing that mobility come to pass, where I don't ever have to do that again.
I must have hit that magical age too, because the same thing happened to me, where I'm answering all these questions on social determinants of health and things like that. I mean, repeatedly over different doctor visits just last year, and I'm answering them on an iPad. And I went back to the person. I said, I know you're not going to know this answer, but who's capturing all this data? And would they send it to the next guy? Because it's just ridiculous, all this stuff you have to answer. It's crazy. Dr. Jadakin, how about you? From a futuristic standpoint, what do you think?
So I know the time is limited. So I think that the encouraging news is we see leadership at Health Current in the innovation space. I think that the opportunity in the future to customize data elements, red alerts or red flag alerts is going to be critical. I think I'll end off by saying that an opportunity, and this is speaking somewhat to Amy's comment, is the interaction between primary care and specialty care is a huge gap in our healthcare system. And that relates to communication, sharing of records, transparency. Did the patient have the test? Yes, no. If they had the test, do I have the results? Duplicated testing. So the NCQA has a program called Patient-Centered Specialty Practice, which discusses from a quality point of view, but I think dovetailing very nicely into the opportunities with Health Current HIEs in customizable products to look at what those 5-6 elements are at that interface between primary care and specialty care to increase quality. And I think that the key functionality here is really a very robust health information exchange system amongst all stakeholders. And I hope that is the future for us. So I'm excited.
Mm-hmm. Very good. We've got just a couple of minutes left here in our program, and I'd just like to kick it open to all of you on our panel. Any last words? Anything that we missed here that you feel like you need to throw out there to our audience?
Get your flu shot, please.
Good one. Dr. Wilson, yeah.
I know that there was one question that came through on the chat room about the role of HIE and DCS. And what I'm going to say is, children in the child welfare system, they need a team taking care of them. And there's so many different disciplines, caseworkers, legal issues. I think the more we think about, the HIE is a great convener to bring our very fragmented systems together. So I think it's going to be a great opportunity to think about who are other people that we need to, with the appropriate roles, have access and get this information so that we have a whole picture of every child and or every vulnerable person.
Yeah, every vulnerable adult, child, everyone. That's for sure. That's a good point. It's true. Well, we are about at that time, and I would really like to thank all of our panelists. All of you have done a fabulous job. I know Health Current is putting on a great program here, and this is a huge benefit to everybody. So, round of applause.